So prostate cancer is different from many tumor types is that it typically does not grow in lumps that are easily measurable. There are cases early on where patients will show evidence of disease in lymph nodes at the time of surgery, but the most common site of spread of the disease is to bone, where getting a three-dimensional look is very, very difficult. When I first started in this field, we did have bone scans, but they are actually measuring the response of the host to the tumor. It doesn't measure the tumor directly. And one of the changes that happens with prostate cancer is the bones become more sclerotic and denser, if you will, as opposed to lytic, where you can actually see destruction. When prostate cancer spread to bone, which is the most common site of metastasis, what happens is the bones become denser. There's a reactive change, which is very difficult to quantitate. And that doesn't mean it can't grow through a vertebra and compromise the spinal cord, but it can cause pain, can cause loss of sensation and motor function. And these are really some of the most feared complications. So one is looking to develop drugs for the disease. You need a quantitative measure to show that, in fact, you're having a favorable effect on the cancer. So the measurements that are typically used are prostate-specific antigen. We see a decline if a tumor is dying and getting smaller. It's very difficult to quantitate bone because you're just looking at essentially more calcium, and you don't have an easy way to show that there's a change in a dimensional change. And in patients in whom there is soft tissue disease, which can be spread to a lymph node or through the lung or liver, you can measure these changes. But almost half of the patients do not have that kind of spread. So we've been working on ways to understand favorable effects on prostate cancers that spread to bone. How does cancer get to the bone? It goes to the bloodstream. And there are ways to identify the cancer cells as they are circulating. If you think of this intuitively, the cancer cells that ultimately seed to other sites in the body do so through the bloodstream. And these can be identified. They can be counted, they can be profiled, they can be studied for different proteins and different molecular changes. But what really started sort of the efforts in prostate cancer was being able to measure the messenger RNA of PSA in whole blood. And one of the first tests we did was to look at a group of patients in whom PSA levels were very, very low. What we're trying to do, the technologies to profile disease are increasing day by day. CTCs are just one of the components of blood, of tumor products in blood that can be studied. There's a very intense and elegant work being done on cell-free nucleic acids. We also have exosomes, and again, a range of biomarkers, each of which has to be studied in fashion. Can you measure it reliably? Where's the unmet need? How is that going to help you with the decision and then the clinical program?